Good morning and welcome back to day 3 of the Missouri Immunization Conference. I'm Nicole Cope, Executive Director of the Missouri Immunization Coalition. Before we get started today, I'd like to remind you of a few housekeeping items. All attendees will be muted for the entirety of the conference, but we would still love your participation. By clicking on the Meeting Hub, you can see a list of the people in attendance. There you can find your colleagues and set up conversations with them, just like you would do an in-person event. In the resource gallery, you can access speaker presentations and the exhibitor handouts. When a session is complete, please return to your timeline. From there, you can visit the exhibit hall and join the next session. We encourage you to visit all our exhibitors. You may speak with them using the chat function, video function, or check out the resources they have available. When you visit our exhibitors, you will be entered into a drawing to win door prizes, which include tickets to various sporting events from universities throughout the state. If you like taking notes during the presentation, please take advantage of the notes field. When the conference is over, you can email your notes to yourself and they will be divided by each session. Please use the live Q&A section to submit questions, and we will ask them on your behalf at the end of each presentation. If you would like to take advantage of the closed captioning feature, please press the CC button under the video window. If at any time you need technical support during this conference, you may email cehp@missouri.edu or call 573-882-4105 for assistance. So let's get started. Our first presenter today is Dr. Mark Ellis. Dr. Ellis has served the largest provider of healthcare, Cox Health, in Southwest Missouri for 22 years. First as a residency faculty, then for 17 years as a full-time clinician. His work envisioning and building a new practice between 2015 and 2022 has given him a passion for helping physicians be healthy, engaged, and purpose-driven. He serves as the physician lead for Cox Health Initiative for Physician Resilience and Enrichment, a multifaceted intervention that seeks to assist physicians throughout their practice lifespan via prevention of burnout, forward-thinking practice management, foundations education, and opportunities for volunteerism. Today, he will be discussing the COVID-19 pandemic's emotional toll on healthcare providers. Thank you for joining us, Dr. Ellis.
Thank you, Nicole. It's a pleasure to be here, and perhaps I'll get to meet many of you in person someday. But in the meantime, I am enjoying the opportunity to consider together the impact of the COVID-19 epidemic on the emotional life of a variety of healthcare professionals. I start with a quote from a great American poet. Perhaps we can relate to this, related to our experiences with COVID-19. There is a pain so utter it swallows being up, covers the abyss with a trance. Memory can step around, across, and upon it. Today, I would like to consider the setting in which we found ourselves at the advent of the COVID-19 pandemic, the roles that we adopted in response to the pandemic, personal and emotional toll on us based on what we had to do, and then perhaps some lessons learned so that next time we have a pandemic, or in the continued pandemic we have now, we'll be able to help each other and help the patients we serve. 2019, January 19th, the first case of COVID-19 occurred in the United States in Snohomish County, Washington. And at that time, we were really quite unprepared for what would follow. It's difficult to adequately summarize our level of preparedness, but I think it's safe to say that there was a lot of disagreement about how much danger the COVID-19 epidemic would pose to our country. We had no treatments at that time. There was no unified public health plan, no unified plan for many aspects of the epidemic as it was developing, and plenty of poor quality or, quite frankly, wrong information on the internet. Politically and otherwise, we had a divided nation, a nation of medical haves and have-nots. So poverty, racism, political divides were present, which would subsequently challenge us as health professionals. And in some quarters, and more people than I would like to say had and have a distrust of healthcare industry and even healthcare professionals. That was the setting in which we found ourselves in 2019. So in come the professionals, and I'm representing not every professional by this slide, but one incredible strength of our healthcare system is that we have dedicated nursing professionals, public health professionals, pharmacists, physicians, and many other types of health professionals who stepped up, did their part at great personal cost. And that's actually why I was happy to say I would be involved with this session. Really is that I'm quite proud of how people did, and I wanted to celebrate that in a way. So again, I think that when we are at our best, our healthcare successes come from each type of healthcare professional doing what we do well in our own sphere of care, but in cooperation with other types of healthcare professionals. And really, as with the picture on the bottom, I think that it's very much the case that our areas of expertise and the areas in which we can help overlap greatly. We don't always realize this as much as we should, but I think that's very true. So even though our spheres of influence overlap, I would like to take a moment to review some of our customary roles in healthcare delivery. And I am going to miss some roles because, frankly, there's not enough room on the slides to put everything that each of you does. But traditionally, I'll say that registered nurses are expert in both the assessment of patients' needs, operationalizing and our healthcare to patients, coordinating the care of patients with a variety of health professionals, and they are experts in health promotion, ensuring quality of healthcare, ensuring safety, and of course they're at the front line and have continued to be so with hospital-based care of the sickest of our coronavirus epidemic patients. Of course, physicians, as we know, prevent, diagnose, and treat diseases and order tests in order to do so. And we prescribe medications and other health measures. We provide a great deal of health advice, and we assume overall legal and ethical responsibility for the care of the patient. Of course, so do other professionals in their spheres of influence. Pharmacists have important areas, of course, including ensuring that our supplies of medications are well regulated and within the scope of law, ensuring that they are prescribed appropriately and administered appropriately, advising patients about side effects and risks of medication, compounding prescriptions, and educating and supporting the public and clinicians. And then in recent years, pharmacists have been really important in enhancing the reach of our vaccination programs. Public health professionals, I can't say enough about how proud I am of how our public health professionals have done, and we'll talk about that later. They're, of course, important in health policy and management, the area of tracking our biostatistics that are key to the health of our country, environmental health services, epidemiology, being a resource for healthcare providers, and administering key public programs such as WIC, immunization administration, etc. So those are some of the key roles of our healthcare professionals. Now let's look at how, as a country, how we did in responding to the COVID epidemic. Well, initially, many people downplayed the danger, as do some even now. Unfortunately, there was a great distrust among some quarters for public health experts, including the Centers for Disease Control. As we all know, the rolling out of testing was not seamless at all, and we did not have universal success with contact tracing, isolation, quarantines initially. Mask guidance seemed to change frequently. Initially, the fact of airborne spread was not appreciated or understood. We still, even when we were getting going on mobilizing some resources, there is a real challenge to get resources where they're most needed because of structural racism that has impacted our healthcare system and access to care. And it was very difficult to launch a centralized response. Now, what were we doing right? Well, our development of vaccines was unprecedented and amazing. We had and continue to have heroic efforts by healthcare workers at great personal cost. Some of the public did their part in helping with prevention and paying attention to and honoring the recommendations given by health experts. The media, many of the science journalists worked very hard to help prevent the spread of misinformation that was so prevalent and still is. Local health departments worked very hard and had to be in a very public setting, oftentimes paired with politicians. And that was a difficult dance to do. And I would say that initially our vaccine distribution and administration was not a strength, but over the course of the pandemic, it became really an amazing strength. So here are some of the ways that our United States COVID response went well and not so well. So during this response, we had to adjust to a new and unprecedented threat. And so the roles of healthcare professionals changed in some important ways. And I'd like to talk a little bit about some of the changes that occurred as a response to the pandemic. Let's talk about nursing professionals. Well, nurses, again, are at the front line of healthcare, especially in hospital settings. And so they assumed great personal risk of catching COVID themselves and of even dying. The coronavirus epidemic intensified the nursing shortages. So not only were nurses exposed to coronavirus, they were working with a situation of being frequently having to do overtime work, extra shifts. Their primary worry was not wanting to infect others, family or selves. They found themselves increasingly as the frontline communicators of information about coronavirus to patients and families. And in this situation, they had to handle a very difficult mix of patients' personal health views that often did not all with what the data was showing. Well, you can see by this slide one of the impacts that this change in role had on nursing staff. This was deaths of healthcare workers through December 23rd, 2020. And you can see that nurses were overrepresented in this. And so deaths of nurses, this just highlights how vulnerable they were. And support, I think, would be nursing support to the nurses. It's hospital-based also. So if you include other healthcare workers in the hospital setting, that is really overrepresented here. This slide talks about the increase in hours of overtime work, and this is actually from Canadian study, but it really bears out in the data for our country too. So if you can see, nursing professionals are 2019 is the dark blue, 2020 is the lighter blue, and you can see that over March, April, May, you can see the dark blue or the light blue going way up, and this is number of overtime hours. So that is a remarkable increase. So these two slides are representing the risk of death to nurses and the marked increase in numbers of overtime hours. The average weekly overtime hours in May of 2020 is about 11 overtime hours per week, which is a pretty significant burden. Now we'll move to physicians. Of course, physicians also are frontline, so there's that risk of infection as well for physicians. Immediately, we had to switch gears and provide much care online and put off other types of medical care because of the need to respond to coronavirus. And so surgeries were put off, a lot of other types of care was put off. Patients just weren't coming in, or when they were coming in, they had COVID. And so the types of healthcare rendered differed at first, and then there was the catch-up care that was rendered. There are physician shortages that were significant also. Exhaustion, burnout are huge issues with physicians and will continue to be so. Also, physicians had to deal with the fact that many people trust their personal physician, but do not trust any kind of thing that smacks of organizational medicine. And unfortunately, politics has entered the room in a big way. It has been emerging, but physicians had to navigate the difficult conversations that involve political views. As part of that, there have been and continue to be lots of discussions with physicians about fringe treatments and patients seeking to justify and even have prescriptions for treatments that really don't have basis in scientific fact. Managing and triaging ill patients was a significant concern, and then much care for a time was switched over to telehealth. So here's one slide about one of the challenges. You can see that about 74% of the American public in this Pew study states that they have mostly positive views of medical doctors and research scientists, and only 8% have a negative view. That's of doctors, scientists, 68%, 7%. So most Americans do have a positive view of their physician. But this is a little more complex slide. This talks about skepticism and political ideology related to political party. So if you see that if you look, the severity of COVID with the severity of high severity, there tends to be low distrust as the COVID severity in terms of amount of COVID in the United States is high or higher. You have more of a level of distrust among people who identify themselves as Republicans versus Democrats. The questions have to do with opening up of the economy, and basically what this slide would show is that in these categories, throughout the pandemic, Republicans tend to believe that opening up the economy was necessary. Republicans tend to believe that are more fearful or distrustful of coronavirus vaccines, and also tend to have more of a distrust of large medical organization, and also tended to believe that COVID-19 had uncertain origins. Now, there's a spectrum here, and many people fall in the moderate range, but you can see that politics had definitely entered the room in terms of factors affecting the COVID pandemic. This is a slide that has to do with the rise of telehealth care in the United States over the pandemic. And you can see that number of encounters more than doubled during the pandemic. Percentage change was, well, it's close to a 200% change. So this is significant and continues to be significant in terms of how people are rendering medical care. So the summary of the impact on nurses and physicians: nurses had the highest death rates and shortages of physicians, and large segments of the population questioned the origins and severity of COVID, the safety of COVID vaccines, and the trustworthiness of public institutions. And during the pandemic, telehealth arose as the most frequently used care alternative. Now we go on to pharmacists. Pharmacists, especially because care was initially, people were not accessing their physician because of either the direct impact of COVID or fears about that. Pharmacists became really, in many cases, the biggest factor in keeping the healthcare system afloat. They still had to provide medications, advice, immunizations, things like that. They initially had a marked increase in providing prescriptions during time of low physician availability. Their advising functions increased markedly. They had to deal with scarcity of supplies and medications, medicines such as ivermectin. Masks were frequently dispensed by pharmacies. And again, they were front lines for vaccine information and then later on in COVID-19 vaccinations. So this slide talks about the professional roles of hospital pharmacists during the COVID epidemic. And you can see that they have many roles, but they especially had to be involved in questions related to medication management, developing treatment protocols, managing supplies of medications, serving as experts on what medications were indicated for COVID treatment, and of course, stewardship of the antimicrobial medications. The community pharmacists had to be accessible to healthcare providers, clarify many misconceptions and questions about COVID treatment, a huge role in screening patients for COVID-19, and continue to do their important roles in medication administration, some involvement in telehealth services, managing chronic conditions, and consultations about some health conditions for which people would typically go to the physician, but during problems of access, the pharmacist had increase in those roles. Public health professionals were incredibly impacted as well. Most public health officials were reassigned to managing the COVID effort, which meant that they were not doing other valuable public health functions. There was a mass exodus of public health officials. I'm not sure how much of this had to do with the COVID, the pressures brought to bear by the COVID epidemic, but there were leadership positions that were unfilled. Of course, we've already mentioned the distrust of the public health services by a sector of the public and the politicization of public health efforts. You know, for a period of time, you would always see a public health official along with a mayor or a governor. So that was an interesting role that may have been a bit uncomfortable, I'm imagining, for the public health directors in states in which there was lots of hesitation about the efforts that the country was taking for COVID epidemic. And as I said, there was a languishing of some of the non-COVID public health functions. So this slide shows during the pandemic the percentage of efforts that were given to various public health purviews. So, for example, we can see that prior to the pandemic, as an example, 11% of the work of public health officials went toward environmental health. During the pandemic, 8%. Maternal child health, 13% of efforts went toward this prior to the pandemic, only 8% during the pandemic. Chronic disease programs, 21% pre-pandemic, 13% post-pandemic. And you can see that 65% of public health officials were involved in COVID-19 related functions. So this is a remarkable slide showing how we had to switch gears in our care of patients from the public health sector. Again, to underscore this, the types of public health functions, we can look that public health officials are involved in public health policy, administration, health education, planning and preparedness for health functions, and others. During the pandemic, you can see that health educator functions, 15% were involved in this, but then in the pandemic, only 11%. Preparedness and planning increased from 16% to 21%. Disease investigation increased from 22% to 30%. And again, most of the effort, or 2/3 of the efforts, were related to COVID-19 pandemic. So this is a huge change in the role of public health professionals. So now I finally, if you guys are still awake, I'm gonna ask you if you wanted to indicate to us a few ways in which you were impacted by COVID, and how did this impact your ability to perform your professional calling. Maybe Nicole can take a few responses, and you can share a story or two.
Hi, Dr. Ellis. We do have a note from Miss Lisa. Sir, I hope I'm saying your name correctly, Lisa. She says, this is a very worthwhile presentation. I was an infection control practitioner at a facility from the beginning of the pandemic until December 2021. Then the totality of its toll on me mentally led to me to leave that profession. She says it is very difficult to take care of staff and populations that really don't want to comply with any recommendations. She's very frustrating and disappointing.
Thank you for that response. It's tragic, the burden that has brought to bear, and I hope we can provide better resources for people such as yourself who have worked so hard, so that this is helped in the future. Any other stories or comments?
I don't see any other stories being shared as of yet.
Okay.
But I did have a question if your presentation would be available. And yes, Dr. Ellis's presentation and all the other presenters' presentations are available in the resource gallery. So feel free to take a look at his presentation again, and any of the rest of our presenters.
And once at the end, we'll have some additional time. So if anyone thinks of additional stories, we can, of course, entertain those at the time. Okay.
I did have one more come in, Dr. Ellis. This is from Miss Linnell Phillips. She says, I recall that my colleagues in public health did not get a day off for months at a time. Like from March 2020 to late fall 2020, not one day off. I know it took a toll on them. I think finding a way for public health folks to get a day off if this happens again is a critical lesson learned.
Thank you. More than one day off. Yes, thank you so much. Well, let's go on. Speaking of days off, maybe we should transport all of the public health professionals to, I don't know, the Alps or something, and give you guys some time in this meadow. But unfortunately, that has been, we're not totally out of the woods, and people are still working extremely hard, and I salute those who are doing that. So let's switch gears a little bit and talk a little bit about the mental health toll that our situation has placed on mental health, upon health professionals. It's a little typo there. It should be health professionals. We've been a little bit in a situation sort of like the myth of Sisyphus, the old Greek myth where Sisyphus had to push a boulder up a mountain, and then it rolled to the bottom and he'd have to go and do it again. It's sort of the never-ending burden. And I'd like to put just a few studies up here. First is a meta-analysis of more than 53,000 participants, 28% of them physicians, 44% nurses, and 7% allied health workers, among others. In this study, they looked at the pooled prevalence of post-traumatic stress disorder, anxiety, depression, and distress. And then the second study was a meta-analysis of more than almost 76,000 frontline medical workers that looked at PTSD, depression, anxiety, somatization, and sleep disturbance, looking at the pooled prevalence of these. And then also addressed burnout, concern about health, and concern about transmitting the virus to the family. So if you combine the results from these two meta-analyses, the incidence of, or the prevalence of post-traumatic stress disorder ranged between 24.5 and 49%. So think about that. Almost 50% perhaps of these healthcare workers had post-traumatic stress disorder symptoms. Anxiety similarly was about 25 to 40%. Depression 25 to 37%. Stress, distress, and burnout were also high, with a burnout rate here of 31.8%. Almost 15% of participants had reports of somatic symptoms associated with this. And about 2/3 had concerns about transmitting the virus to their family members, and almost 40% had sleeping difficulties. So this is a whopping impact. If you look here, these are some of the prevalence rates in the second study, the Bush study. You can see that symptoms of PTSD in this study, 24.5%. Perceived stress, just a general perception of stress, was present in about 57% of participants. About 60% were concerned about transmitting the virus to their family, and about 45% were concerned about their own health. So these show significant prevalence of significant burdens of illness. In this, you can see that there were various risk factors for mental health problems among health professionals and various protective factors. The significant risks for mental health problems would be the level of disease exposure. So if you were a hospital-based bedside worker, you had higher level of disease exposure and therefore a higher level of risk for mental health problems. If you perceived that you were in a high risk situation, this risk perception and fear, you would also have a greater risk of mental health problems. And then others, many of them trended toward a statistically significant result. Here with protective factors, organizational communication and support among your organization was a big factor that would bring protection from mental illness. And then social support and a sense of control and coping ability also were associated with protection against mental health problems. So as we look at things that can be brought to bear on future epidemic preparedness, I think we need to look at organizational changes and supports, and giving our healthcare workers a sense of control and over their problem that they're having. So again, increased risk for mental illness would be a level of disease exposure and risk perception and fear, and decreased risk for mental illness would be organizational and community support, social support, and a sense of control and coping abilities. So this is just I'm honoring the bedside work of all those who worked in the hospital and are still doing this. Let's talk a little bit about the burden on nurses. Sleep disturbance is a huge problem based on a meta-analysis of about almost 7,000 health professionals, 3,745 of them nurses. Almost 35% reported significant sleep disturbance of all of these in here, with nurses reporting in actually several studies reduced sleep quality, increase in depression and anxiety, and fears of being infected or infecting others. So among nurses, sleep quality, depression, and fears of infecting self or others were really very high prevalence. In fact, the COVID period has witnessed poorer mental health outcomes among nurses, especially with PTSD, anxiety, and depression, than with physicians, although both have had significant burden from these. So if you look at slide shows that in these areas of mental health, nurses comparing the need for treatment or the need, the burden of this type of illness among physicians versus nurses. Okay, so if you look at depression, nurses had 12 studies in this meta-analysis indicated that nurses had greater problems with depression requiring treatment than did physicians. If you look at anxiety, 15 versus 4, so depression, anxiety, PTSD following the black line. So in all those cases, medical doctors had less of a burden of illness than did nursing staff. Now, if you look at stress, there was a mixed picture in those. Both medical doctors and nurses had stresses. Most of the studies found that they had an equal amount of stress. And then with burnout, the majority of the studies showed that nurses and doctors had an equal amount of burnout, equally divided. Two studies showed nurses having more burnout, two showed physicians having more. So basically this shows that, again, nurses have had more trouble with depression, anxiety, PTSD, somewhat mixed picture with stress and burnout. All right, related to the impact on physicians, physicians that had a rise in burnout, depression, and suicidal ideation, some barriers to care, and there are consequences there. In a Medscape survey of physicians, 2021, the burnout rate in physicians is about 42%, and 79%, interestingly, had symptoms of burnout beginning before COVID. 21% had additional symptoms after COVID. 13% of respondents had suicidal ideation, and they dealt with the problem by seeking help from their administrators and seeking reduction in work hours unsuccessfully. or by isolating themselves, poor eating, alcohol, drugs, smoking, trying to reduce their hours. They wanted to have more control over their schedules and have more respect and control. So this is a snapshot of physician burnout, and in part the burnout has to do with the COVID epidemic. It's instructive that for physicians, there are very few, and I'm using physicians as an example, but I think this is the case with all kinds of health professionals. Physicians who are very unlikely to participate in any programs designed to help with burnout. That's one problem, but another problem is only 35% of workplaces where physicians work actually have well-being programs that are geared toward health professionals per se. Physicians tend to deal with their mental health problems by minimizing their symptoms or trying to deal with them themselves or not dealing with them at all. And a healthy minority state that they do not want to even talk about their problems because they don't want them to be disclosed. So I use physicians as a bit of a canary in the mine for other health professionals as well. I suspect that we don't have enough workplace programs for dealing with the types of stresses that came from the pandemic, and that many people are not going to participate, and they will unsuccessfully try to deal with the problems themselves. The consequence of burnout, in part related to the COVID epidemic, are things like intent to leave practice, actual leaving practice, impact on healthcare for patients, adverse impact, and individual health consequences for physicians. You can see that, again, depression is pretty prevalent, and among physicians who had suicidal thoughts during the pandemic, only 1/3 sought treatment. Again, I think this can be generalized to other health professionals as well. So at this point, we've talked a little bit about the mental health consequences of the pandemic. I'd like to finish the talk by talking a little bit about questions we can ask in hopes that this will help the next time as we're dealing with the current pandemic and the next time we have one. Well, first of all, we ask why do physicians and other healthcare professionals get burned out and have mental health consequences of things like a pandemic? A general definition of burnout would be chronic stress and intense work demands for which resources are inadequate. And so excessive workload, work inefficiency, lack of work support, loss of control over their work, loss of meaning from their work, all are factors involved in burnout. Problems with the team, erosion of the team, lack of recognition for what we do, burden of responsibility. I'll bet these things all sound familiar. I think every kind of health professional has these similar things. So how do we prevent this? Well, the next talk, I believe, is going to talk a little more specifically about this, but I'll talk about just 3 factors. One, we need to foster resilience in healthcare professionals. We need to work on improved collaboration. And finally, we need to work on interventions that protect from burnout. Resilient healthcare provider, or the resilient practice, has qualities that enable us to adapt well and even thrive in the face of adversity. I would say that the performance, for example, of nursing professionals and health departments was incredible. They did so much important work, but personally, were the people working in those situations adapting and thriving? Well, probably not. But if we're able to having good self-knowledge of what our risk factors are for mental health problems, and care for ourselves, and have a realistic view of what we can and can't accomplish, that can help with resilience. Building good professional relationships is incredibly important. Team building, especially because if you're in isolation, you'll have more burnout. And then patience, gratitude. Hopefully we'll sometimes get thanked for what we do. Strong collaborations are incredibly important. I just put one example of a type of a collaboration that's important. There's a study, a really good study of the strength of nurse practitioner physician practice within a shared patient panel, and basically the better that physician nurse practitioner relationship with it is in terms of communication, mutual respect, a shared care philosophy, the less burnout there is, and there's a decrease in the intent to leave practice. This is important as we develop collegial relationships over time. Also, other interventions that have been shown to protect from burnout include organization-directed interventions, such as workload and schedule changes, opportunities for professionals to have group discussions about the state in which they find themselves work-wise, some protected time, including time off, focus on communications and teamwork. Individual provider-directed interventions that help could be mindfulness, stress reduction, communications training, even things like incentivized exercise program. I encourage you to look into some of the things that we've seen in the literature and go to your organizations and ask them what resources do they have and what could be brought to bear in future times. So the question I would have for each of you is, what have you or what has your business done to foster resilience, enhance your professional or personal relationships, or prepare for future epidemics or professional stresses? So we can open it up to some questions for that. We've got a few minutes on that.
I don't see any questions coming in yet, Dr. Ellis, but for that particular question, but I do have one that says, healthcare workers have seen many people die due to COVID-19, including family members and colleagues. What resources could employers include in their benefits to preserve the mental health of workers?
Well, I think there has to be easy, confidential access to high quality healthcare. And that's often not very easy to get with established practitioners who work within that same healthcare system. I know that in our healthcare system, we are starting to develop programs for some really good quality face-to-face online kinds of counseling, professional services for healthcare professionals. And I suspect that's going to be an emerging help for that. But I think also there need to be some focus groups and organizations in which you bring out the problems and ask your administrators, challenge them and say, we need to come up with things that are workable where we don't feel stigmatized and yet we have access. At hours, we can have the access.
We have another question that says, do you feel that young people, having watched the trauma of the medical community over the last several years play out in the media, will be discouraged from pursuing medical training?
I fear that that may be a problem. However, the generation coming up and is a very one that has lofty ideals, and I think people's desire to help and desire to really make a meaningful impact on our struggling nation will bring people into healthcare. But we need to have them appreciated and appropriately compensated for what they do in various ways.
Our next question is, how can a healthcare provider take care of their mental health while they are providing services during a global emergency such as COVID-19 and when the industry needs extra hands?
This is a real challenge. Each person has his or her or their amount of time they need for recovery and for sleep and eating and basic things like that. On the one hand, a crisis energizes people, but then they'll have the inevitable fall down after that. So I think there need to be systems put in place to safeguard and be watching people carefully for signs of burnout. But I think there need to be established programs for burnout prevention well before there's a problem. And we can't rely on people to simply work more hours as a response. Uh, there have to be limits on how much we work. You know, it's not humanly possible. You have to take care of yourselves too.
Um, I've been in the healthcare profession for a couple of decades myself, and I found that if you don't take care of yourself, you can't take care of others.
Yes. And they should let their spouses and significant others and family help reflect to them if they see that there's a problem. So there need to be multiple entry points toward mental health resources, including others helping us, mentors helping us, well-designed systems put in place that are confidential and that are directed toward the needs, the specific needs of healthcare professionals.
We had a comment come in, not necessarily a question, um, that says, I found this and I love this idea of a virtual room of refuge with a link to the virtual room of refuge. Have you heard of anything like that, or what are your thoughts on that, Dr. Ellis?
No, I don't. I haven't heard of it, but I would love to have the respondent share more about that. Maybe we can get that. It sounds like a fun place to go. You know, we have a little room in our cancer center here. That's a it's a quiet room for just contemplation and prayer, and and you know, I think we all need those spaces. And we need to have that honored too. And they should be also physical spaces in hospitals too.
We've had another comment that came in that says, I am still in school for my Master's of Public Health. Something that I've seen from my peers and faculty is that we don't shy away from the realities of the pandemic has brought on us. We have all been struggling, but it's validating openly talking about these things inside and out of the classroom rather than ignoring reality.
That's great to have a set of peers with whom you can share these realities. And I hope that you'll continue to have that kind of interaction even after you finish your very important graduate work. And I think we need to develop interdisciplinary formats such as what we have here, where we can all share that. We don't get together often enough. Yeah.
We have another comment that came in that says, I worked in public health as a COVID disease investigator from August 2020 to April 2022. The emotional labor was intense. I agree with Lisa in that, especially at the end, no one was interested in taking COVID recommendations seriously. So I felt frustrating to continue calling people to attempt to help keep them, their families, and the community safe. I dealt with a lot of exhaustion and burnout despite wanting desperately to be involved in helping keep people safe. I have a deep respect for our healthcare workers who were on the front lines.
That's beautiful. Thank you.
We have another question that says, what is the medical education system doing to make sure that students are equipped with crisis and coping mechanisms to weather the trauma and burnout they will inevitably see in their future careers?
That is a huge and very important question. Studies would indicate that burnout starts very early, including during training. In fact, it increases throughout the residency programs, and the greatest period of vulnerability is actually during the first 5 years of practice. So that's part of what we're starting to work on in my healthcare system. It's a huge need. Various residency programs do it better than others, but I think that there needs to be really global work on this, and it's too big of a question to handle in the time we have, but it's a really important one. Maybe we can talk next year about, talking about this during educational venues. How do we equip the students?
Those are all the questions that we have, Dr. Ellis. I'd like
Okay.
to thank you for joining us today. And at this time, we welcome all of our attendees to visit and interact with our exhibitors. We want to remind you when visiting with our exhibitors today and tomorrow that you will be entered to win a drawing to win door prizes, including tickets to various events from the universities throughout the state of Missouri. Our second speaker today is Dr. Craig Rooney from the Office of Clinician Wellbeing at the University of Missouri Hospital and Clinics. He will be talking about self-care for healthcare professionals. And until then, we look forward to seeing you at 12:20. Thank you.